Thank you, Dr. Marin, Dr. Padiletti, ladies and gentlemen. It's my pleasure to present this study to you on behalf of my co-authors, Dr. Aya Kino, James Carr, and Dr. Robert Bono. Hypertrophic cardiomyopathy is the commonest monogenic cardiac disease and the commonest cause of sudden cardiac death in young people. Though the majority of community patients with HCM have a benign clinical course, adverse clinical events occur and are often unpredictable and quite diverse in nature, reflecting the phenotypic diversity in this disease. The prediction of adverse events or adverse clinical course has become a high-interest pursuit of physicians caring for these patients. Although sudden cardiac death is the most devastating adverse event in HCM, other adverse events occur, including diastolic heart failure, non-sustained ventricular tachycardia, and refractory symptoms requiring septal reduction therapy. While clinical markers of adverse events, as we have seen, have been recognized for some time, the positive predictive value of these markers is low. Interest has therefore been focused on imaging characteristics of hypertrophic cardiomyopathy that may be used to predict the clinical course in these patients. The one morphologic feature of hypertrophic cardiomyopathy that has most convincingly been demonstrated to be associated with an increased risk of sudden death is magnitude of left ventricular hypertrophy. In this landmark paper by Dr. Spirito, Dr. Marin, and colleagues, we saw that the increased wall thickness is associated with increased risk of sudden cardiac death. About a decade ago, we from Northwestern showed a non-invasive way of detecting myocardial fibrosis in these patients using gadolinium-enhanced cardiac MRI. The myocardial fibrosis that was detected actually tracked with increasing thickness of the segments of the left ventricle. This was called gadolinium hyperenhancement. Since that decade, there's been an explosion of interest in using cardiac MRI to morphologically characterize these patients further. A study done soon after ours was from the Brompton MRI group in London, who showed that the extent of myocardial scarring or fibrosis detected by cardiac MRI is greatest in patients with multiple clinical risk factors for sudden death, and in those patients who have end-stage HCM with left ventricular dilatation and heart failure. The myocardial scarring seen with cardiac MRI, represented as delayed enhancement, has also been linked to the presence of non-sustained ventricular tachycardia. And as we heard, that ventricular arrhythmias are postulated to be the most common mechanism for sudden cardiac death in this disease. More recently, I would draw your attention to these two studies, which have linked myocardial fibrosis and hypertrophic cardiomyopathy with reduced survival. And indeed, the incidence of probability of adverse events increases with the increasing percentage of late gadolinium enhancement detected by MRI, and this is higher for the longer years of follow-up. Again, this graph here shows that the scar percentage in the left ventricle is highest in patients who have had cardiac death or all-cause mortality. With this backdrop, our aims were to investigate the interaction between left ventricular maximal wall thickness and scar or fibrosis, two common morphologic features of hypertrophic cardiomyopathy that lend themselves well to evaluation with contrast-enhanced MR in hypertrophic cardiomyopathy, and their association with adverse events such as repetitive non-sustained ventricular tachycardia, or NSVT, septal myectomy for refractory symptoms of left ventricular outflow obstruction, or diastolic heart failure, defined as volume overload requiring diuretic therapy. 87 patients with hypertrophic cardiomyopathy diagnosed by established criteria were studied. Late gadolinium enhancement magnetic resonance was performed using a 2D PSIR turboflash protocol using the contrast medium gadopentate dimeglumine. The maximum wall thickness of the left ventricle was measured, and the percentage of late gadolinium enhancement was quantified using automated software. The patients were grouped in according to the percentage late gadolinium enhancement of the left ventricle and maximal wall thickness. The development of those adverse events, NSVT, diastolic heart failure, and septal myectomy, were compared among the subgroups of SCAR less than 10%, 10 to 15%, and SCAR greater than 15% using ANOVA. An unpaired student t-test was used for comparison of percent SCAR between categories of maximal wall thickness. The patients were a mean age of about 50 years, and the follow-up period between the cardiac magnetic resonance and documentation of adverse events was about 17 months. Myocardial scar, defined as late gadolinium enhancement by contrast MR, was present in 81% of our patients. The mean scar mass was 38 grams with a large standard deviation, and the scar percentage mean was 25%. The mean ejection fraction in this group was 67%, so these were not patients with end-stage hypertrophic cardiomyopathy. The mean maximum wall thickness was 18.8 millimeters. Maximum wall thickness was significantly greater in patients with late gadolinium enhancement compared with patients without LGE, and this was statistically significant. The amount of scar was also greater in patients with maximum wall thickness greater or equal to 2 centimeters than those with wall thickness less than 2. And this was also significant. Adverse events occurred in about 40% of our patients. This is an example of a patient who's a 32-year-old woman in this study who demonstrated asymmetric septal hypertrophy in these short-axis images of cardiac MR, where the maximum wall thickness was 3.1 centimeter in the anteroseptum, and she had a large scar burden with a mass of 107.4 grams, calculated to about 60% of the LV mass. This patient had repetitive non-sustained ventricular tachycardia on a Holter monitoring and had an ICD implantation for primary prophylaxis of sudden cardiac death. So when we look at the number of patients with these different events in the different scar categories, we see that as this percentage scar increases to over 15%, all of these events of NSVT, diastolic heart failure, and septal myectomy increase in this population. It is much lower in patients with less scar. When we look at the interaction of scar and wall thickness with adverse events, what we see is that those patients with the left ventricular maximal wall thickness of less than 2 centimeters and no scar by late gadolinium enhancement really had no events, whereas those with wall thickness less than 2 and scar had these events, which was not statistically significantly different from those with wall thickness greater or equal to 2 centimeters with scar. This is a diagram putting those two together to show you the adverse events in the different categories of scar and maximum wall thickness taken together. So bear with me as I explain the x-axis of this graph. So here we have patients with no scar or maximum wall thickness less than 2 centimeters who had no events. Patients with maximum wall thickness less than 2 centimeters were divided into those with scar less than 10%, 10 to 15%, or greater than 15%. And you can see that the events increased in the patients with scar over 15%, even though their wall thickness was in the moderate range, which is less than 2 centimeters. Now, patients whose maximum wall thickness was greater or equal to 2 centimeters had events even with a low amount of scar, as well as with a very high amount of scar. We had no patients in this middle category. So what do these data tell us? Well, hypertrophic cardiomyopathy patients with maximum wall thickness less than 2 centimeters without visible scar on late gadolinium enhancement CMR, we found have a low risk of adverse events. Adverse events, the corollary of this, are most likely in patients with scar and maximum wall thickness greater than 2 centimeters. The amount of scar, especially that greater than 15%, appears to be most likely to be associated with adverse events regardless of maximal wall thickness. In patients with maximal wall thickness greater than 2 centimeters, even a lesser amount of scar is associated with these specific adverse events. Now, this is a small study with small numbers in our subgroups. We did not have enough appropriate ICD discharges, cardiac arrest, or sudden cardiac death to analyze for this study. And the follow-up period is relatively short. Thank you for your attention, and thank you to the scientific committee for giving me this opportunity.
Thank you, very interesting. I just wonder, I understand it's a small study, but the standard deviations for your both the percentage as well as the absolute amount are pretty broad.
Right.
So how is it that can we use these data as we try to apply it to a given patient?
You know, I think we need larger numbers of patients to increase the size of the subgroups and the subcategories, which may give us a tighter standard deviation for these patients. I think that's a limitation that, you know, we can't really overcome with the size of the thing. But I think the signal is there that the amount of scar and the amount of magnitude of hypertrophy are both important in the management of a single individual patient that's before you. And I think we have to individualize that.
Thank you. Did you check the classical risk factors in these patients? I mean, at the same time that you evaluate the LVH and fibrosis, did you check if they have familial sudden death, if they abnormal?
Yes, those were assessed in all of those patients. I didn't report the data here because we were focusing on these morphologic characteristics for risk stratification.
Did you find any relation? I mean, the people that they have fibrosis, did they have also other risk factors?
You know, the classical risk factors were quite few in these patients. You know, especially non-sustained ventricular tachycardia wasn't, you know, we looked at it in relation to one of the outcomes of this disease. So, you know, they were not, like many of the patients did not have a family history of sudden cardiac death, for example. Many did not have an abnormal blood pressure response. There were many without extreme hypertrophy, as we know are classical risk factors. But we looked at these classical risk factors in relation to this study with these outcomes in mind. So we looked at their wall thickness, but we divided the wall thickness into different categories, if you know what I'm saying.
Thank you.
Thanks very much. My name is Dermot McCaffrey from Ireland. I was just questioning the diastolic heart failure definition. I haven't heard of it. Evidence of volume loading requiring diuretics. Was that a patient presenting to their GP or into a heart failure admission with BNP elevations, etc.? I mean, was that it seems a very soft endpoint.
These are patients who have preserved systolic function, have RALs, have symptoms of heart failure, and have edema, JVP, and they are treated with diuretics, but with preserved systolic function.
Lubna, very nice study. I have a question. Did you look at the distribution of LGE? I mean, we feel that that matters, and do you have any data on this?
In most of our patients, LGE was located to the most hypertrophied part of the myocardium, which in the majority of our patients was septal hypertrophy. To be exact, it was mostly the mid-septum, anteroseptum.
And did you see any subendocardial?
We did not see any subendocardial LGE in these patients.
Congratulations, clean and wonderful data. Some technical issues. Do you really trust measuring LGE using as a null signal a part of the ventricle which is, is diseased? I mean, do you think that we should change the way we measure LGE in this disease, which are disease of all the ventricles. So you use as a null signal, a signal in which there is interstitial fibrosis, which is not, shouldn't be better to use a null signal out of the body or in the muscle?
Well, the definition of LGE is late gadolinium enhancement. Excuse me. So that means that by definition, we look at visual scarring when we wait for the gadolinium contrast after 10 minutes after administration. So that's the definition. So this is to make it easy for people without doing further analysis. If you have an MRI person just reading it, and they can just see it, and it's visualized scar, basically. And I agree with you that the disease is, all pervasive, and there is, of course, interstitial fibrosis, but we think that LGE does not represent interstitial fibrosis. It, represents more replacement fibrosis in this disease.